mode.
Hello, and welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for joining. In today's program, we'll be looking at how your PQRS decisions will impact your VBM score and reimbursement. Before I introduce Tom Lee, remind everybody that you will get a copy of this recording and the slide deck accompanying it within 24 hours after our event. Our expert, of course, is Tom Lee, founder and CEO of SA Ignite. Tom was instrumental in establishing the Chicago Health IT Regional Extension Center and has consulted for leading healthcare and health IT organizations across the country. He is a national expert on MIPS and leads the development of MU, PQRS, and VBM software and services for SA Ignite. Tom, how are you today?
Very good, Carol. How are you?
I'm doing fine, sitting here in sunny Arizona, but excited about today's program. You know, it's generating a lot of buzz out there, so looking forward to hearing what you've got to say, and then we'll move into the Q&A. So I'm going to go ahead and give you control here, and I'll see you back in a little bit on the Q&A.
Sounds good. All right, well, great to be back, and I wanted to just quickly review some key takeaways from our last MIPS webinar that really segue nicely into our discussion today. Last time we talked about how overall the MIPS potential financial impact is quite large, potentially even 30% difference in Part B payment adjustments between the winners and the losers in the program as it rolls out. And that really starting in 2017, most likely is going to be the first performance year of MIPS. Today, we're going to really see the impact then and now around the value-based modifier quality scoring system. And by way of review from last time, the 0 to 100 point scale of MIPS is designed such that 30% of that score will actually be driven from the PQRS VBM quality scoring that we're really seeing today in the market. So we're really going to zoom in on this part today and really let you all understand and have some good discussion around how does it really work, what are the impacts, and what can we really do to optimize for it. So today, we're going to start out with a primer on the VBM quality score and how it works. Then we're going to actually move to some real field examples of how suboptimal PQRS decisions can really negatively impact the score quite dramatically, as well as the reimbursement. And we will talk about 4 specific recommendations that have really emerged from serving clients as well as really being out there in the market. And then finally is an interesting opportunity, a free opportunity that our company has put together to really help you identify what your provider organization's quality score vulnerabilities and opportunities might be for VBM, and then how that relates to ultimately moving on to the MIPS system. We'll also quickly review some other resources out there. I want to put a plug in for our Open MIPS LinkedIn group, which I'll have more to say about later. It's quite exciting. We're writing a batch of comments that could submit into the MIPS legislative process, rulemaking process, and we'll end with some Q&A. So let's get right into it. What is the VBM quality score? For those of you who have received or looked at a QRUR report from CMS, you may have seen different numbers on there and whatnot, and that's where you'll actually find your score. That's basically the report card for the VBM program. But let's look at really what it means. So imagine that you're CMS and you're able to really rate the standalone quality performance of each individual organization and plot them on a curve where the horizontal axis is a particular level of quality, and the vertical axis are the number of organizations that have that level of quality. So it's basically a histogram. And that's the basis for how the scoring is really defined. It first starts out with understanding what is the national mean or the national average performance level across all the organizations in the country under Part B. Then for those of you who may be remembering things from your statistics classes or otherwise, but it doesn't, don't let the terminology scare you if not, is that this distribution has a certain spread, or otherwise known as a standard deviation, which basically describes how tightly or broadly the providers vary in performance across the country. Okay, we're going to call this standard deviation, or just SD for short. And this is the foundation for how the score is actually defined when it comes to your organization. And really, in a nutshell, what it is it's how far above your organization is. Let's say this dot is your organization on this curve, that you have this level of performance going from the national mean. The score is basically how far away from this mean your organization is in terms of your quality performance, as the number of standard deviations away from this mean your organization is able to achieve. So for example, the standard deviation where your one standard deviation away is roughly where the hash mark is right here. So in this case, this organization has a score of about 0.5. Actually, I just saw the typo here. This should actually be positive 0.5 instead of negative. So we'll go ahead and fix that after the fact. But that's what the distance of 0.5 is. Okay, so this is really ultimately what's driving reimbursement, is how many standard deviations you are above or below this mean, and that's literally what the score is. And some of you who read through a QRUR report, which by the way will be the subject of a future webinar here, so stay tuned for that as those reports become available for the 2014 year, is termed the SQCS. Okay. Now, let's talk about, okay, how is this score actually calculated? I'm going to put a big blue box in the middle, which is just the VBM algorithm. Okay, there's a lot of kind of moving parts within there, but for right now, it's a black box to look. Let's look at what inputs go into that black box, blue box in this case. First are all the reported PQRS measures from your organization, as well as from every other organization in a given performance year across all PQRS reporting methods. That's the quality performance. Second is that on the CMS side, they're able to calculate the measures on their own side, which are claims-based quality measures that are separate and apart from the PQRS measures that actually also evaluate your quality. Some of those measures actually even go beyond the outpatient or the ambulatory setting and measure things such as the readmission rate on the hospital side. It's the fully loaded quality of that particular provider. And finally, on an annual basis, CMS provides value-based modifier quality measure benchmarks that are used to really rate individual measure performance. Now, all of those things get crunched into the algorithm. And what pops out is the score for your particular organization rated on that bell curve I just showed in the previous slide. And the reimbursement impact of that score is as follows for the current 2015 performance year in terms of percentage adjustment to your Part B payment. And in this case, we're just, for sake of simplicity, going to just talk about this for organizations that have at least 10 PQRS eligible providers in their respective tax ID. So if the score falls between -1 and 1, then it's 0% adjustment that's then relevant for the 2017 payment year. If it's above 1, meaning that you're a 1 spread or 1 standard deviation above the national mean, it's going to be a positive 2% for you. If you are below, worse than 1 standard deviation below, it's -2%. Okay? That's at a really high level what goes into the score and what really comes out, and this is the reimbursement impact. One real interesting note, for those of you who may be in MSSP ACOs, the Medicare Shared Savings Program ACO, is that this is the first performance year in which your providers are also going to be subject to value-based modifier. Okay, and we'll come back to that because there's very prescriptive quality reporting requirements for ACOs, and then your question may be, well, how do I optimize for value-based modifier as well if now I have to also worry about that? All right, so let's get into a little bit why it is that making decisions about PQRS measures and what methods to use for reporting PQRS can matter greatly in terms of what your VBM quality score is going to look like. Why is that? So let's take a specific example around one method which is common, which is PPRS registry reporting, whether it's GPRO reporting in terms of group reporting, whether it's individual provider, where you can pick 9 measures across 3 quality domains to represent the quality of your providers. And the whole kind of art and science of selecting measures has been around for a while, for registries. But now really because of value-based modifier being really true pay for performance with national peer ranking as well as a whole new algorithm, the game has really changed around how to select measures. So the first and most important point is that now one really has to look carefully at whether the measures you pick actually exceed the VBM measure benchmarks published by CMS annually to see if those are quote-unquote good measures or not from a VBM perspective as opposed to from any other perspective. The second, and we'll see this in some examples, is that the score for VBM is actually very highly sensitive to outlier measures. You can have 1 measure out of 9 that if it has poor performance can have an outsized effect on your VBM, and we'll go into some real numbers from the field in a moment. The other is to really look at, in terms of how the measures are grouped into those 6 different quality domains, is you need to basically put on the lens of looking at your measure selections through the lenses of those different quality domains, because VBM actually calculates a quality domain score separately for each of the 6 domains and really goes, really rolls up the entire score from there. So you got to think in terms of domains, not just in terms of individual measures. That's measure selection. Now, method selection, that can also be complicated. One example is this age-old question about whether or not to report providers individually or as a group. And if you speak to peers or you look over at the market, the spectrum spans a wide range. There are 700 and 800 physician provider organizations that are reporting providers individually. There are also groups as small as 2 or 3 providers that are reporting as a GPRO. And that decision actually can have a very significant impact on whether or not the VBM score is going to be as high as you could make it. We will see examples of this as well. If you report providers individually, then it turns out that VBM puts a harsh spotlight on outlier providers, and they can really drag down the score quite substantially. The other point to consider are that the measure values that your organization may have for a particular PQRS measure number, the value of the measure could be drastically different between whether you report and calculate through using a registry or whether you, for example, use the CQMs coming out of your EHR to report through EHR Direct or the DSV mechanism. Okay, so lots of variation, lots of considerations. All of these decisions can have a market impact on what your VBM score is going to be. So let's go through some real examples, actual examples from the field of how much can this really matter. And the first example is around selecting PQRS measures. There is a case that we've come across in our experience where measures were selected for PQRS without evaluating any of the potential VBM score impact as I described above, and where the quality score really ended up actually close to -1, which is getting dangerously close to the negative penalty area. But then if you compare that, if you then ask the question, let's apply to the very same available patient data. The patient data is all exactly the same, but we only change the actual selection of measures that we choose to report. This is what happened, is that the VBM score actually skyrocketed to the point where it really took a real negative situation and turned it to a very positive situation in terms of almost being on the cusp of actually getting an incentive rather than a penalty. It can be this large simply by making the measure selections differently than in another scenario. Of course, the real trick here, and we'll show you some examples of this, is how do you know when the score has maximized? How do you get some predictive power on the score? That's one example. The other example is around the reporting method. I mentioned before in terms of individual provider versus GPRO. So there's a case where an organization really decided to consider reporting individually, providers individuals, about 200 or 300 providers. And when they actually went in working with us, we were able to find out that their score was going to be quite low by doing so. Then compared it to the other scenario, where reporting as a G-Pro instead would actually cause their score to increase by 1.7 on this scale, which that's a 2% gain right there. Okay, so that method decision that many of you all went through in terms of to try to decide whether to do G-Pro or not, that passed June of last year, think forward to next year. The rules around G-Pro are going to be different, or they're going to be slightly different every year. The June 30th deadline for next year is something to really try to get ahead of early, perhaps even during your submission season that we'll be entering in Q1, to really start thinking about and reevaluating whether or not your past decisions around G-Pro versus individual are still going to be valid going forward, particularly in light of things like this on the value-based modifier. Okay. All right, and really we've seen the opposite occur too, where G-Pro can actually result in a lower score rather than a higher score. So you really have to look at your data and understand the situation to really know which way it's going to be and whether or not it's going to be a significant difference or not. Okay, so here we get into the recommendations. I'm going to show you some visuals that actually help to motivate, what we might be able to eventually provide you, okay, as a kind of a benefit to the community. But we'll get into that later. But I want you to remember these views because we will come back to them. So the first recommendation we have is really through whatever means is possible, really try to estimate and compare what those VBM scores are when you actually change up your measure selections. Okay, so here's an example. Is let's say my EHR or registry vendor only supports these measures, okay, just for sake of argument. About 15 measures, and I need to select 9 measures across 3 quality domains in order to meet the minimum reporting requirement for PCRS and VBM. Let's say I start out with set 1, where these measures are selected. And I estimate that will give me a 0.5 on the score, which will result in no payment adjustment. Now the question is can I do better than that? And one way to try that, to see if that's the case, is to start changing up the measure selections, which changes the set of data being submitted. Really re-estimate that score and see where that lands, and so on and so forth. And experience has shown that the difference of 1 or 2 measures can cause pretty wild swings in the score. But hopefully you're fortunate enough to find one combination here that really puts you really as high as you can go. Okay, and this could either be for an individual provider, or this could be at a G-Pro level. So really, whether you can do this analysis on your own or not, you want to seek help on doing this, the point is to be sensitive to the fact that you change these measure selections, it changes what domains are going to be included in your reporting, which in turn is going to have a large impact on what the score is going to be. Okay? That's sort of the first recommendation. The second recommendation is a little bit more subtle, but actually is quite actionable in terms of just trying to improve your performance, throughout the year. And what that recommendation is really try to find those measures that have the highest impact on the VBM score if you can improve those measures, and then actually focus on improving them. Okay, and what I want to first kind of describe is how this type of analysis could work. This is the way that we do it. You all may have many other ways of doing this. The way that we do it is that we look at, let's say, the 9 measures, and let's say, for sake of simplicity, that you have no choice on those 9 measures, that your organization has already decided it's going to be these 9 measures, or you're a G-Pro, or you're an ACO, and you have to report the 17 measures through the G-Pro mechanism. And so then your only recourse to improve your VBM performance is to actually try to improve performance for each of those measures that you're mandated to report. Okay? Now, in order to identify which measure will give you the biggest bang for your buck is where we come in and we apply what we call a stretch analysis. And so what that means in words is that we take one of your measures and we, let's say, add 75% to it. We stretch its performance and we increase it by 75%. And then that little fudge factor is factored into basically reprocessing all of your measures to see whether or not the score, how much the VBM score will go up by. Okay, and this is what it looks like visually to kind of help you out here. So for example, let's just take two examples here. Let's say here's the baseline score. In this case, with the measures the way that they actually are in terms of performance, it's now at a minus 1.5. What this stretch analysis does is it takes just this, let's say this first measure, and just adds 75%, 50 to 75% of increased stretch on it. Okay, and then that's going to obviously cause the whole score to increase once the score is recalculated. And in this case, good, but not good enough. Still in the penalty region, still at about a minus 1.2. But then you repeat this process for each measure successfully. You're only isolating the stretch on each individual measure until finally, again, if you're fortunate, you can either get into the neutral region, or you can get out even into the positive region. And so what this graph is telling us is that this measure down here, for the same amount of increased stretch or increased performance, will actually cause the greatest increase in the VBM score. That is where your improvement efforts should focus, is on this particular patient safety measure. Okay, so this is what we call basically a leverage or a stretch type analysis. But again, you may have other ways of doing this, but this is a very useful way to identify where are your lowest hanging fruit opportunities to increase your score with the same amount of effort in terms of improvement and workflow and training and so on and so forth. Okay. All right. All right, so moving on here, I think we're doing pretty good on time. We might even be able to have a little bit more time for Q&A. The third recommendation is this is all around comparing how your VBM score may be under using different reporting methods, such as we discussed with respect to individual versus GPRO. The other axis to look at are just the different types of reporting, beyond whether it's individual or GPRO. As I mentioned before, different methods can give you very different measure values for the very same PQRS measure number. The other part is if you look at the amount of administrative work that you may need to do under any one of these different methods, they can also be vastly different. And there's another consideration is the cost of actually doing one method or the other. This is something we often work with our clients on, and there's a lot of complexity here, and there's very rarely a perfect answer. But at the end of the day, it's really about understanding what kind of risk your VBM score might choosing one method versus another actually net you, and what might the opportunity be. All right, so the recommendation for is actually recognize, embrace, and then weigh the trade-offs, because there's very rarely a perfect answer when you make these PQRS decisions. And let me try to add some color as to why that is. Why will you be facing, or have you already faced, conundrums in trying to make these decisions? Let's first look at selecting PQRS measures. So, in the old days of just the PQRS program way back when, it was really all about how can you get measures most efficiently and easily and at lowest cost, and simply report them to CMS, because at that time the measures were not going to be publicly reported, and you were not going to be penalized or incentivized based on the values of those measures at all. It was all paper reporting. But now, in light of paper performance and the public reporting of these measures, the game has completely changed in terms of selecting measures. And here's the things that it starts to knock up against. Okay, the first thing is that every organization has other quality initiatives going on internally, which may put a very strong bias towards picking a particular set of PQRS measures because the providers are really aligning some consensus around those measures. But those measures may not necessarily be the ones that right now will yield you the highest value-based modifier score, because there could be other measures that are not getting as much focus in your organization, but that could be performing much higher than the VBM benchmarks than the measures you have picked, and thereby you're going to have to make a decision. What's more important to you, alignment with your quality initiatives, engagement with your providers, or maximizing the VBM score? The question then becomes, how much of a cost on the VBM score might I pay if I want to serve these other masters? Okay, it's complicated. You have to be looking at the trade-offs and making a conscious decision about it, and really letting your senior leadership understand the trade-offs. The other trade-off is reputational impact. Is with these measures being all publicly reported and identifiable in 2016 through Position Compare and downloadable by any third party, there are some interesting conflicts between what measure might give a cardiologist the highest score, for example, whereas that measure may be a primary care measure that has nothing to do with a cardiologist's workflow, and consumers are going to see that, and you have to think about, or your marketing department might think about, do they even want to have that measure out there for the cardiologist? Okay, and so that's another interesting trade-off in terms of what you have to consider. Now that's the measures. In terms of the reporting methods, it has its own set of tensions. So administrative burden and costs, you could have a reporting method that can definitely give you the highest VBM score, but at what administrative cost? What kind of vendor fees might be involved, things like that. You have to weigh that against whether or not it's going to be worth it. Another thing that's interesting, obviously, I think many of you all have experienced with this, is there might be some real serious system limitations. Some of the EHR vendors did not support, for example, a G-Pro EHR direct mechanism or vice versa last year. And you have to really know that going in and really understand that you might not be able to have the highest VBM scoring method available to you because of those limitations. And when you pick a method, it also relates to the area of selecting measures, that the method may only allow you certain measures out of the ones that you actually want to report that you're actually going to be able to do through that method. Okay, so there's a lot of trade-offs here, and none of these are light decisions. I encourage everyone to really think deeply about these things and really have those conversations to make sure everyone is aligned around what the pros and cons are. Okay, so let me move on here. Okay, there we go. Okay, so if I may just do a little bit of an essay ignite plug. I know all of you have been great these last couple sessions. I do want to be very specific here about there's one particular area that I think may be of interest in terms of a free opportunity to really help identify some of your vulnerabilities and opportunities on the score. Is that basically what we're going to do after this webinar is really look at the whoever is in a provider organization is among the first 10 provider organizations that register at a link that I'll show in a moment, and that satisfies some implementation requirements that we would subsequently let you know about. What our company has really put together and put a lot of thought into is that we're basically going to deliver a free set of VBM analysis reports using your 2014 reported and unreported PTRS measure values, okay, through whatever PTRS method you use, whether it's EHR Direct, web interface, registry. So we're agnostic to that. And we're going to really work with you to get that data for each TIN and each provider that you may have the data for. And from that, we can run it through our VBM analysis to identify those vulnerabilities and opportunities that's basically going to give you reports that look like the ones I showed in those first two recommendations regarding how your score may change with different measure selections, or how it could have changed if we could go back in a time machine to 2014, as well as what measures can give you the greatest leverage on your VBM score, potentially going forward to the extent that this year may be similar or different from what you did last year, okay? And here's the link. We tried our best to make a small, tiny URL here, but look, if you can't have enough time to write it down now and you really want to start registering for this, you can also send me an email, and I will be very happy to email the link to you as well. Okay, so I'm just going to maybe leave that up here for just a moment for those of you who like to copy it down. This is a little bit harder. This is actually a G for George here. Okay, P3V3GT6. All right. So we look very much forward to learning from all of you who are able to participate in here in this particular opportunity, and we'll also look forward to doing what we can do to kind of give you some insight into what your VBM opportunities may be, and also some of the things that you may want to be conscious of moving forward and trying to improve things. Okay. All right.
There we go.
So Carol, I think we're doing pretty well here.
We do. We have 30 minutes for Q&A.
I know. I love it. I love having more conversation time. One last thing. I mentioned a little plug here for our LinkedIn group. We have about, last time I think it was about 30 members, many of whom actually came right off of the webinar series. So thank you again, Carol, for giving us the opportunity. It's a completely open group. It is privately moderated now, but if you go to LinkedIn and you search in groups on merit-based incentive payment system, you can request to join our group. I will get the notification and be very happy to add you into the discussion. There's a lot of activity now around how to really draft a set of interesting comments around the MIPS legislation that is due September 8th as CMS's first round of initial comments. And there's some really interesting topics around, how do you determine whether providers that are doing Part B at a low volume, at what point do they become part of MIPS, what point should they be excluded from it, and a variety of other questions like that. So we'll look forward to hopefully meeting more of you then and getting your thoughts on how you think it should play out in the actual final rule. Some other resources, many of you have seen these before, is on our website. If you click resources on our website, you will access a number of things. Our FAQs about MIPS right now is actually doing quite well. If you Google merit-based incentive payment system, I think you should still see the #1 ranked link actually are these FAQs. And thank you all for, many of you all in this webinar community have actually contributed some of the questions that we ended up answering, so thank you for that. And very specifically, one of the FAQs that have been of particular interest is that, for those of you who were not on the last webinar, is that we created a free Excel-based MIPS financial calculator where you can run different scenarios and put in numbers relevant to your organization and find out under MIPS over a 4-year time horizon, what is your maximum possible payment adjustment for Part B and what's your maximum possible penalty. And this has proven to be fairly useful for, I know, a number of provider organizations. As well as some questions, real kind of working levels is just really start to get ready for MIPS. A lot of it's about asking questions. Folks within your organization, letting them not only know that MIPS is coming, but to really better understand how they're doing and how they will do their part to really prepare for MIPS, because these 3 programs make up 85% of MIPS. So really, it's never too early to start on that path.
Right.
Yeah. Okay.
All right. Q&A time.
Thanks,
I like
Carol.
it.
Awesome.
So just there are a lot of questions right now from the attendees for today, and we actually got a lot in the registration as well. So I'm going to tackle those first. If we don't get to your question today, whether it was asked during the registration process or on today's webinar, please email Tom at tom@saignite.com. And he'll get back to you, and you can email me as well, as always. Well, so Tom, let's dive right in and answer some of these questions. First is from David from Texas, wants to know, describe the connection between MIPS and Medicaid MU attestation. Medicaid, not Medicare.
Sure, absolutely. So strictly speaking, MIPS is really only touching Medicare Part B. So if we're talking about Medicaid MU, that's really on a completely separate track. But it does raise also an important point of awareness, is that in terms of the Medicare meaningful use side, MIPS does not touch the MU incentives at all. It simply consolidates the penalty side of Medicare MU. But for Medicaid, it's completely separate and apart from it.
In fact, Medicaid's got a longer tail than the Medicare side of MU as well. Excuse me, Lynn from New Jersey asks, do you advise specialists to report electronically given the paucity of relevant CQMs that they have for e-specifications?
That's a wonderful question. And frankly, the whole question of specialties and selecting measures for specialties relates to one of the points I had in the slides around one of those tensions, one of those conundrums around selecting measures. If you're reporting through GPRO Some organizations like the fact that the specialists can ride on the back of the primary care measures for GPRO using EHR Direct, for example, but other organizations really don't like that. They really want to actually give their specialists a lot more measures that they can really engage with and be held individually accountable for. I think what that question really relates to is when you go and you look at what methods you want to report through, there's obviously some interesting attraction around EHR Direct because it's all automatically calculated by the vendor. On the other hand, if you really desire to engage your providers, your specialty providers, through this quality measure and these value-based programs, and you may also be subject to other quality initiatives. It might be around cardiology, like Million Hearts campaign, there's a lot of these other things that might tilt you in favor of doing registry, for some period of time because you want to get that engagement. And it's really not clear yet in terms of how quickly the CQMs on the electronic side are really going to expand to really be a lot more specialty focused, on the with respect to EHR Direct. One other emerging new area is really the QCDR mechanism around where there's really much more specialty focus, and that might be another thing to take a look at as another potential option for reporting.
Somebody emailed me asking the definition of paucity. It's P-A-U-C-I-T-Y. It means scarcity. Carol from North Carolina, can you talk a little bit about your experiences with submitting eCQMs as PQRS measures or populating domains with single or group measures? Talk a little bit more about that.
Yeah, and I'm sorry, Carol, could you repeat the second part of that question?
Sure. Can you talk a little bit about your experiences with submitting eCQMs as PQRS measures or populating domains with single and group measures?
Yes, got it. And so I believe the second part of that question was around, whether reporting individually or reporting as a group.
Right.
I think it was probably the question was probably around single measures or group measures.
Right, right, not provider.
Yeah, got it.
Right.
Yeah, got it. So, our experience around, so first the experience was around EHR Direct. Great question. Probably we have a whole other webinar on EHR Direct.
Right, right.
In our experience, we have helped a significant number of providers through that process. Contrary to popular belief, it is almost never as simple as downloading a file from your EHR and uploading it to CMS. There's a lot of setup that's got to be done typically, and also some of the vendors that I alluded to before only support individual provider reporting for EHR Direct or only support GPRO, but more and more of them are doing both. It's going to take a little while. One of the things to really try to get ahead of way before the submission time for EHR Direct, which is February 28th, is to what extent has your vendor tested their QRDA file through the actual PQRS testing tool? Because what happened was that the certification process for EHRs was essentially using a different flavor of QRDA than the flavor of QRDA that CMS will electronically accept. Now, in the new certification rule, they are plugging that hole. But it's going to probably be another 12 to 24 months before you're really going to feel in the market and those files end up being exactly the right format. So there were a number of organizations and vendors even that really got caught behind on this the last submission round and barely got their files through in time. So that's one thing around EHR Direct that I think is very important, to try to get ahead of. In terms of single measures versus group measures, what's being really talked about there is in the registry mechanism. You can choose to report 9 measures individually, or you can, in particular if you're a specialty, instead choose a group measure mechanism through registry, which is where you only have to report 20 patients for each measure. Let's say if it's the cardiology group, but you must report on every single one of the measures in the cardiology group measures. Okay, so it's somewhat of a trade-off in terms of you can be more focused on a specialty, but you have no choice about the measures that are handed to you by CMS in that group. Okay, that's just one trade-off there to be conscious of with respect to that. So.
Okay, Catherine from Missouri, how are we supposed to know the benchmarks for each measure so that we can ensure our performance % is high enough?
That's a great question. So it turns out that CMS on an annual basis does publish the VBM benchmarks. I believe it's in the VBM section of CMS. I haven't looked recently, but the thing to look for is called a prior year benchmark. And the latest one that will be coming out fairly imminently in the next month or two are the actual benchmarks for the current performance year, where they use the 2014 national data to set benchmarks for 2015 VBM performance. Okay, so if you have trouble finding that, send me an email. I'd happy to point you in the right direction. But that's where it's available now. Now the other part really is, and this is kind of the part really which is around the opportunity I discussed to work with our company, is that once you have those benchmarks, you still need to really understand and really build out the machinery for actually trying to estimate what your VBM score is going to be. Okay, because if you simply look at the measures and you choose the measures that are all the highest relative to their benchmark, that doesn't guarantee you're going to get the highest VBM score. Because, for example, if all those measures are only in 2 quality domains, you won't even meet the minimum 3 quality domains that you have to span, for many of these reporting methods. Okay, so then you got to start playing games with how you distribute your measures across different domains, and your score may not be as high, but it will at least be a valid submission. There's things like that you have to really consider in making those decisions. So.
Right. Nancy from Georgia, how does CMS define peer groups? Basically, they're measured against
I love this question.
The great question.
I love this question.
By specialty, region, size of practice. It's a great question. Who are your peers?
So, and to really level set here, the question is a great one, and what's really around is in value-based modifier quality scoring. And many of you may have seen this in your QRUR reports. You're basically put into a peer group, and the peer groups, the only entity that knows the number of peer groups that have been set up is CMS itself. Okay, but in working with a fairly large number of clients, kind of seeing their QRUR reports and kind of seeing that what we can identify is that there's definitely a multitude of different peer groups out there. No one, again, other than CMS really knows how it is they define what peer group you're going to be in. But what I can say is that there are some high-level characteristics that seem to be indicative. So, for example, if you're a couple hundred physicians and you have several hundred providers, there is one peer group that you'll probably be part of, okay, that we've seen before, but it's not necessarily the case. You kind of have to take it on a case-by-case basis. So it's an awesome question. I wish I could give a better answer. Maybe if someone from CMS here were sitting beside me, they can give us more insight. One thing we have seen is that it does not appear to have a strong geographic bias.
Okay.
It doesn't seem to be too as regional, because if it were, then we wouldn't be seeing some things that we have seen. So that's the only real kind of insight I could provide on that one.
Okay. Cindy from Nebraska, if a provider leaves an organization, does the penalty follow or stay with the organization?
So it depends on what program you're talking about.
Right,
right.
So
for VBM, it's possible for one, for one provider to be billing under 2 different TINs, and thereby have the provider's payments under both of those different TINs be adjusted differently, right? Where let's say both TINs reported using GPRO, and one TIN did great and the other one didn't, then the provider's billing could be getting positive on one side, negative on the other. As a kind of general rule of thumb, it's really often the unique combination of TIN and NPI number. That is what CMS really recognizes. But for VBM, and I could probably, as a follow-up, really look at the exact reference and section in the rule. That I believe that if a provider switches TINs, they don't pull their history along with them to that new TIN. Okay, that they're just then subject. Their new billings under the new TIN will just be subject to whatever payment adjustment has already been earned by that TIN, you know, separate and apart from that provider even for that performance year.
I'm actually going to, oops, hold on one second. Sorry. I lost my, here we go. This is Elizabeth from Illinois. Is it better for you to choose an easier CQM to satisfy and score well? Huh. That's a
great question.
That's a great question.
That's actually where those conundrums. You know,
yeah,
I've
that is a
almost,
conundrum.
you know, it's that one slide I had about knowing the trade-offs. The answer is really it depends. Unfortunately, as any good lawyer would say, is that if your organization is really all about, for a given time, really maximizing, you know, just really maximizing the probability of you know, not getting a penalty or even creeping up into the incentive area of BBM, then often the answer is, you know, that can be the best path for you, you know, to really maximize your score, is to go for the quote-unquote easiest measure. But on the other hand, if you take it from a, let's say, a public reporting consumer side, you know, what your marketing department might say about that measure being publicly available to a consumer, they may give you a very different answer and say, you know, we don't care how well we're doing on that measure. I don't want, you know, my orthopods to be rated on that measure because the consumer will look at it and it won't make any sense to them. You know, so it really depends on what your organization deems important at the time and how they want to kind of work out that trade-off.
Yeah, it's sort of a timeline question from Cindy from Kansas. When are they going to implement VBM for reimbursement?
So the question is already, the chicken's out of the coop.
The chicken, yeah, it's already here, right?
VBM has been running, yeah. You know, 2013 was really the first year, so it's already out there. I think that, you know, what has happened is that the amount at risk has gone up. You know, initially from about plus minus roughly 1%, now plus minus 4%. The other part, which is less known but is also true, is that the number of providers subject to potential negative VBM adjustment has also expanded from only you know, physicians now to other types of providers, and then that will continue to expand you know, as we move forward with MIPS. So just another thing to keep track of. Right.
Another sort of timeline question. When do you see CMS approving the proposed rule? Of course, we're in the initial comment period now, which you said ends September 8th.
Yeah. So if the question is around the MIPS the MIPS rollout, which is projected to be the beginning of 2017, as far as that being the performance year, according to past precedent, we'd probably be looking at the notice of proposed rulemaking really around that NQ1, maybe like the Q2 timeframe, roughly.
Okay.
But because of the need to have the final the final rule approved probably 2 months before the beginning of the performance year, then we're probably looking at October or November to actually have the final MIPS rule for 2017 finalized. But the process is already kicked off as far as the comment period.
Right, and somebody on the audience chimed in, do you actually see any wiggle room in the timeline of 2019 MIPS adjustments based on 2017?
I think the probability is low. You know, and again,
Okay.
that's the opinion of someone like myself who's outside CMS. And the reason why is because if you look at it, MIPS is 60% value-based modifier, and there's been no slowdown historically in the value-based modifier timeline. And I expect that to carry over to MIPS as well. So if 2019 is the first adjustment year for MIPS, just by the machinery of the way that the CMS machinery is designed, you're going to you need like about a 2-year lead time from the performance year to the payment adjustment year for all the reports to come out and all the analytics to be written, and all the providers to be prepared to either get a penalty or an incentive. 2019 is unlike it, and that's built into the congressionally approved legislation that was passed by a 95-5 margin in Congress.
Right.
So that's not going to change with the change of administration.
And that 2-year window, we certainly saw that with stage 1 MU, that sort of timeline. Carolyn from Ohio, will submitting more measures than necessary hurt or help?
That's an awesome question.
It's a great
I
question.
love that one. Yes, it's a little known fact that you actually can report more than 9 measures. For those methods such as registry and EHR Direct, where you only have to report 9 measures, you can report 9. And in fact, we've had clients who reported 20 or more.
Wow. Yeah.
And a lot of that was not necessarily for reasons of trying to improve their performance, because of, frankly, EHR limitations, in terms of not being able to have enough flexibility to pick only the 9 best measures. So you absolutely can. The way in which you find whether that helps you or hurts you is exactly trying to estimate that value-based modifier score with all the inputs I had on that slide, all those arrows going into the blue box. But if you have measures, if those additional measures, 10 through 20, are strongly positive scoring, meaning that they're much higher than benchmark, that very well could lift up your score. It very well could. But I would say the more majority case are organizations that are, more struggling just to find 9 that are even acceptable. Okay. And a lot of it's not because of their actual performance. It's because of things like there hasn't been adequate data capture in the EHR, or that it's going to be cost prohibitive to get a registry company to do enough measure calculation to make more than 9 available to you.
Mm-hmm.
Right? There's all kinds of other factors that have nothing to do with intrinsic performance, but that could limit people, from not being able to report more measures. But I would say absolutely you should consider it if you really looked at it's going to be worth it. But then you really want to consider, well, how much more could it really improve my score? Now, the other part is, do you also want those measures to be reported publicly? And if you really want to have more transparency than your competitor across town in terms of the amount of measures you make public, then that's a separate and apart reason, to report more measures. It all depends on your situation.
All right. Another measures question. Does reporting on specialty-specific measures versus non-specialty specific measures matter?
Mm-hmm.
That's kind of a mouthful there.
Yeah, that's really, for VBM scoring, it's all about the quality domain. Okay, and there's really no categorization by VBM of what specialty a particular measure applies to. It's all about what quality domain the measure, which of the 6 quality domains the measure falls into. So the answer is no. There's no kind of specialty aspect of the measures itself. Now, on the other hand, in relation to the previous question around what peer group might you be compared against within VBM, it is entirely possible that whether it's in the past or going forward, that CMS certainly has the ability to become a lot more specialty focused in terms of what peer group they put you into.
Right.
So that's another thing to kind of look at when you get your QRUR reports. Again, we'll talk about this in the future webinar in terms of how do you read a QRUR report. There might be some clues there that can serve as guideposts as you move forward on that path.
Can you discuss the MIPS exclusion for those and other VMB reimbursement methodologies? VBM reimbursement methodologies, yeah.
Yeah, absolutely. So let's first start with VBM. As I mentioned before, VBM's net of what providers are subject to it has been getting wider and wider with every passing year. The most recent widening of that, applicable to this year, is for the first time ever that all the Medicare Shared Savings Program ACOs are also subject to VBM. Now, and so we continue. You should expect to see that continue to expand on the VBM side for this year as well as for the next year until MIPS entirely takes over, most likely again in 2017. With MIPS, the exclusions are pretty interesting. So there's not only mandated a low volume threshold, which is what CMS is seeking commentary on, which could be revenue based. It could be saying that your revenue must be above a certain dollar figure or above a particular percentage of your overall payments in order to be considered enough of a Part B provider for MIPS to apply to you. There's a low volume threshold piece that's pretty interesting. The other most major exclusion to MIPS, which is built into the legislation, is that if your provider has a minimum amount of payments and billings through an alternative payment model, or they call an APM, an example of which is the MSSP ACO program, as well as certain demonstration projects that the Secretary has approved and have been running for a couple of years now. And just by virtue of a provider being in one of those programs, then in fact, the entire TIN that may be an MSSP ACO is thereby, excluded from the MIPS side. So, and again, well, I should be a little careful about that because some of that is still being in flux, and it will be further defined in the rulemaking. But that's an example of the way it can, of the way that it can play out. So,
right.
But really, with MIPS and the overall SGR fix, or the whole legislation, which is called MACRA, the macro legislation.
MACRA, yeah.
The whole goal is to put Part B providers into two distinct buckets. One of those that are subject to MIPS, and the other that are those in an alternative payment model. And it will be basically two branches that will then really go forward through at least the year 2023.
Do you see any concerns about using your EHR vendor to manage PQRS reporting?
Well, look,
that's an interesting question. Yeah.
There's concerns working really with any vendor all the time.
Sure.
I mean, it's like anytime you involve an external partner, outside organization, there's always things that you should be on top of. With respect to EHR vendors specifically, I think really what a lot of it is really just the mutual understanding that there are a lot of things going on, both on the vendor side as well as on the provider side. But a lot of it is about asking the right question, at the right time. So, for example, have your QRDA files been tested through the PQRS portal? Okay. If so, when? Will they need to be retested? When do you anticipate CMS may update their spec? We want to make sure our EHR direct files go in on time without having it be a fire drill, 48 hours before the deadline. It's about what's your timeline for supporting these additional measures, CQMs, that will be available to us. To what extent have you had other clients provide data to XYZ registry company? I want to know that the data elements that the registry company is going to need are actually supported by the version of software that I'm running. It's a lot of questions like that, and a lot of those questions are derived through talking to folks that have had a lot of experience in a lot of different situations with PQRS and with many different, EHR vendors, and they can kind of share that experience with you. So,
right. Yeah, good question. And we've got time for one more question, and then we'll wrap it up. Some of my private providers individually report through registry. Will CMS calculate all measures reported through all mechanisms?
Yes. The short answer is yes.
Mm-hmm.
CMS has stated for VBM they are using all measures through all mechanisms. That has an interesting additional question attached to it, which is, it was just last year, in fact, where the VBM program first allowed organizations reporting providers individually to actually be rated under VBM. Because you may remember in the early days of VBM, it was only GPRO, it was only group reporting. And for those of you who are committed to reporting providers individually, you just want to make sure that at least 50% of your PQRS eligible providers are reported individually, so that therefore you will meet the minimum VBM requirement. That's what they call the 50% rule, okay? And that's another thing to just make sure that you reach the 50% of your providers threshold when you report individually, so that then you're going to be able to avoid those VBM penalties, or the automatic VBM penalties.
Right. I just want to remind our audience, if we didn't get to your question today, you can email Tom at SAIgnite, or email me, Carol at hightechanswers.com, and I will make sure to email Tom at SAIgnite. Tom, thank you so much for your time today. I look forward to next month's broadcast, and thank you to our audience for tuning in today.
Thank you, Carol. It's been a pleasure.